On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Thank you, Ajay. Okay, so I'm going to share the results with you from a study called POSEIDON, which stands for Prevention of Contrast Renal Injury with Different Hydration Strategies. I have no disclosures. All right, so contrast nephropathy is a common and serious complication of contrast exposure that results in morbidity, which can be measured as an increase in myocardial infarctions and the need for dialysis, mortality, cost, length of hospital stay. Hydration with normal saline or 0.9% saline remains the cornerstone of contrast nephropathy prevention, yet many important questions remain. Fundamental questions even, such as what's the appropriate rate of hydration, duration of hydration. Also, is a uniform rate appropriate for all patients, or can the rate be individualized to a given patient's needs? In the POSEIDON trial, we tested a personalized hydration strategy for the prevention of contrast nephropathy. Specifically, we asked, does LV-EDP-guided hydration reduce the incidence of contrast-induced acute kidney injury in patients undergoing coronary angiography, or PCI? LV-EDP here stands for left ventricular end diastolic pressure, which is a hemodynamic parameter that is routinely measured in the cardiac cath lab. It provides insight into a patient's volume status. This slide shows the study design and endpoints for the POSEIDON trial. Patients undergoing coronary angiography, or PCI, greater than 18 years of age with an estimated GFR of less than 60 and one additional risk factor for contrast nephropathy were randomized in a 1-to-1 ratio to either LV-EDP-guided hydration or standard hydration. All patients were hydrated with normal saline or 0.9% saline. The primary endpoint was a 25% or 0.5 milligram per deciliter increase in serum creatinine with at least 2 values measured on days 1 through 4. The secondary endpoints are 30-day major adverse event rate, which was a composite of death, myocardial infarction, and the need for dialysis. We randomized 396 patients. 196 were assigned to LV-EDP-guided hydration and 200 to standard hydration. This slide shows the hydration protocol both in the LV-EDP-guided and standard hydration groups. Pre-procedure, all patients were hydrated at the same rate of 3 ml per kilogram for 1 hour. The LV-EDP value was assessed prior to contrast administration at the onset of the procedure. This hemodynamic parameter was then used to determine the hydration rate in the LV-EDP-guided hydration group. For example, for an LV-EDP value of less than 13, and these are pressures, and so this is less than 13 millimeters of mercury, the rate was set at 5 ml per kilogram per hour. For LV-EDP of 13 to 18, the rate was set at 3 ml per kilogram per hour, and for LV-EDP values greater than 18, the rate was set at 1.5 milligram per kilogram per hour. In contrast, the standard hydration group was hydrated at the same rate, which was 1.5 ml per kilogram per hour. The hydration rate was set at the start of the procedure, continued for the duration of the procedure, and then continued for an additional 4 hours post-procedure. This slide shows the main results from the POSEIDON study. The incidence of contrast nephropathy was 6.7% with LV-EDP-guided hydration, compared to 16.3% with the control group. This corresponds to a statistically significant 59% reduction in the incidence of contrast nephropathy with the LV-EDP-guided hydration strategy. The corresponding relative risk was 0.41, and the absolute risk difference was 9.5%. The number of patients needed to treat with LV-EDP-guided hydration to prevent one contrast nephropathy event was 11 patients. This is the first trial to test the hypothesis of an LV-EDP-guided hydration strategy for the prevention of contrast nephropathy. LV-EDP-guided hydration resulted in a significant 59% relative and 10% absolute reduction in contrast nephropathy, a very statistically significant observation. The number needed to treat again to prevent one contrast nephropathy event was 11. Hydration protocol was well tolerated. Hydration was terminated in 1.5% of subjects, and this was actually equal in both groups. The results are applicable to patients at risk for contrast nephropathy, which we estimate to be about 1 out of every 6 patients undergoing coronary angiography, or PCI. The protocol in particular is easily adopted and may be utilized in both the inpatient and outpatient settings as designed. Thank you for your attention.
Great, thanks so much, Sam. Let's ask Alice first, then Ted. What are your thoughts on this? And also put this in perspective, because this is something that, as interventionalists, we're quite familiar with, but it might be difficult for the press or other people to understand. How real is this problem?
Contrast-induced nephropathy is certainly a real problem. Congratulations on a very nice study. It's certainly a real problem and something that we struggle with, particularly in patients who are at increased risk to have this problem. It's usually defined the way you do, which is a rise in creatinine, although it's a number that it's usually reversible. The longer, harder clinical endpoints, such as dialysis, it's a much smaller event rate. I guess my comments are, this is lovely, it's inexpensive, it's easy to do, it seems to work, and it's based on a hypothesis. We know that dehydrated patients tend to do worse and have a higher incidence of contrast-induced renal problems. My questions are, were you able, I know this is a quick presentation, but did you control for things such as contrast volume, overall intake and output? And then my final comment is my non-evidence-based bias over the years has been, it's not really so much how much fluid you give or what the initial filling pressure is, but that you give a high flow through the kidneys. So I might argue that even in the patients with the higher LVEDPs, if you gave a large contrast post-hydration, as long as you took it out with Lasix, they would do just as well.
Yeah, in terms of the baseline characteristics, I didn't show it here, but I'll show it during the presentation. They were very well balanced for all the important things, which include age, gender, diabetes, which are all important risk factors, but then also importantly for serum creatinine, estimated GFR, contrast volume, the groups were really well matched. The p-values were not even close to being different between for those characteristics.
Ted, any comments?
What was the mean contrast volume ballpark for both groups?
Yeah, the median was about 108.
So that's pretty good. Many of the contrast-induced nephropathy prevention strategy studies have gone on about whatever their strategy was without noting that they had typically much higher total contrast volumes. And giving less contrast is far and away the most important single variable. And that you can show any kind of a difference on top of that is really pretty impressive. But I'd also say that the control group just did sort of the quick math for a 75 kilogram patient would be getting 112 cc's an hour. And I think our own template for IV fluid rate for the generic cath patient is 200 an hour because we want to hydrate people. So could you respond to the possible criticism that you've created a straw man with a low volume as your baseline comparator?
Sure. So when we designed this, we kind of assessed to see how often people were actually even using normal saline, which is kind of the fluid that's most recommended by guidelines and position statement papers. And peer-reviewed surveys, which are published in the literature, show that patients undergoing coronary angiography, about only 45% of the patients receive hydration with normal saline. So the utilization of the fluid is actually less than 50% in many clinical settings, especially in patients undergoing coronary angiography. If you take, just to keep the math simple, a 100 kilogram patient and you randomize them to the control group, that patient would get the equivalent of probably about 10 hours of hydration if you hydrated at 1 cc per kilogram per hour, which is, in my estimate, probably more than what a lot of people are doing. I think the benefit here is from a significant volume of fluid around the time of contrast exposure, which helps then diurese out the contrast. I'll show later this morning the analysis by patients who did develop contrast nephropathy versus those who did not for the hard clinical endpoints of death, myocardial infarction, and the need for dialysis. And it confirms that contrast nephropathy is a very serious problem. And you see these endpoints in about 15% of the patients in the trial.
One question.
Dharam Kumbhani from Cardiosource. I want to follow up to Dr. Feldman's comment in the active arm. Can you comment on how you develop the sliding scale? So, for example, someone with a normal LVEDP less than 13, who is 100 kilograms, would receive half a liter an hour. And so, can you comment on how you develop this sliding scale?
Yeah, this was through a very small pilot program, and then also through discussion with experts. You need to develop a protocol that will administer enough fluid to prevent the contrast nephropathy, but not so much so that people would be uncomfortable administering the fluid. So you're right, for a 100-kilogram patient, you could be getting half a liter per hour, and that would continue for the entire duration of the procedure. And if it's a long procedure, you might get, 2 hours there, and it would continue for another 4 hours afterwards. So there was some preliminary groundwork to kind of, figure out that this would be, a tolerable amount of fluid for patients with EDPs less than 12, and they do very well with it. The discontinuation rate was very low.
Great. One last question from Ed. Just also putting this in perspective, I think here at the meeting we've heard about safer stents, making PCI safer by perhaps doing less through techniques like FFR. This is something that is practically free and has been shown to be effective, and it's a real problem for patients. I actually did a case on Friday, and all Monday, Tuesday, Wednesday was worried about the patient because she actually went into renal failure. Today she's fortunately doing well, but I think that this is a great advance.
Ed Sussman with MedPage Today. I might have missed these. How do you determine who is at high risk for nephropathy in these cases? And I also, what was your secondary outcomes?
So to determine patients' high risk, the ones we enrolled, first they needed to have an estimated GFR less than 60, which off the bat kind of identifies the patient population at risk of contrast nephropathy. In addition to that, we required one additional contrast nephropathy risk factor. That could have been history of diabetes, age greater than 75, history of hypertension, or even a history of heart failure. And so patients meeting those criteria met the inclusion criteria for the study. And I think that's why we see the endpoints we do. And I'll show the hard clinical outcomes later this morning.
Great. Well, thanks so much. Let's move on.